Good morning, good afternoon, good evening, all dear colleagues from all over the world. We are back here again in the name of ISAC, International Society of Antimicrobial Chemotherapy. As you know, we have webinars every month about COVID to get in touch with our colleagues all over the world. And this is the fourth one. And today we are going to talk about the treatment, effective treatment modalities of COVID. And we are very lucky to have very distinguished lectures from the different countries. And we will start with the antiviral treatment. And Professor Uzun, she is an ID person from Hacettepe University, Ankara, Turkey. And she's going to talk about the antiviral treatment. And then from France, Dr. Yazdanpanah will talk about the convalescent serum and the monoclonal antibodies treatment. And finally, Dr. Gül from Istanbul, Turkey, will talk about the anti-inflammatory treatment. And I forgot to introduce myself. My name is Dr. Ünal. I am the Secretary General of the ISAC. And again, we are very glad to be with you here for these interesting subjects, and they will speak by turn, and we will get the questions after each lecture. So please, during the broadcast, use chat function to ask the questions, and I'll convey the question to the related people. And without further ado time, I will call Dr. Uzun to talk about the very important subject, the antiviral treatment of the COVID-19. Please, Dr. Uzun.
Thank you, Serhat. In this half an hour, I'll try to discuss the current status on antiviral treatment of COVID-19, where we are, actually. Actually, I can finish this talk with only the following slide. We're back at the beginning. Anyway, but I'll just talk how we started and what are the results of especially some medicine. COVID-19 is a very important pandemic. This is the first pandemic of 21st century with a high number of confirmed cases and a death toll over 300,000 people. And despite vaccination efforts, it is still going on. The numbers are increasing, and that's only the tip of the iceberg, actually. And we do need effective antiviral drugs. Yes, we do. And how can we find antiviral drugs? There are two ways. The first one is developing a brand new molecule, which we are all accustomed to. And the second one is drug repurposing. Drug repurposing is new uses for old drugs. And it is an attractive option because this is a pandemic and we have to act fast. And for a brand new molecule to come to the market, it takes a long time. And there are strict regulatory requirements and the costs are indeed very high. But when an old drug is repurposed for a new indication, the risk of failure is lower, and we have the safety data. We have phase 1 and phase 2 data especially, so time frame for development can be reduced, and that's really a big advantage. And of course, this is going to lead to less investment because of savings from phase 1 and phase 2 trials especially. And in the end, when you introduce a new chemical formulation, it takes $2 to $3 billion compared to only $300 million for a repurposed drug. All the antivirals that we use against COVID-19 are repurposed drugs. How do we repurpose them? We have the old molecules, but how do we select them? We usually do it with computers. There are some methods that are not really familiar with, such as signature matching, molecular docking. But most of the study, the background study is done on the computers, and then they are tried. This is the life cycle of SARS-CoV-2 virus in human cell. It enters the cell, and then RNA is released via proteases, and RNA is replicates, is translated, it is packed, and a new virion is formed, and it is released via exocytosis to infect more cells. And we can have, in theory, drugs that can work in each of these steps, all of these steps. But in practice, we have drugs that work to block the entry, that inhibit RNA release via protease inhibitors and RNA replication. As for the latter part, we don't have effective drugs tested so far. Well, this is an OHEL slide. I tried to put all the molecules I could find in my PubMed study, those with an efficacy against COVID-19. Of course, a few of them have been used in clinical practice, and most of them are just effective in vitro, or they are just the repurposed drugs with an effectiveness in theory. Well, let's go on. Let's start with the molecules targeting viral entry. And we know that ACE2 is very important for the virus to enter the human cell. And ACE2 inhibitors, in theory, can be very effective against the viral infection. And we have several molecules here, but I'm going to talk about chloroquine and mainly hydroxychloroquine. Those are the only ones with clinical trials. The others, we don't have any clinical trials yet. So chloroquine and hydroxychloroquine, those two old molecules, they interfere with glycosylation of ACE2. And in addition, they increase endosomal pH, and that's needed for membrane fusion between virus and host cell. So it is affected. And of course, have an immune modulatory effect as well. So the first study that came out and suggested an efficacy of hydroxychloroquine plus azithromycin was this study, this French study, open label, non-randomized clinical trial. In this trial, 42 patients were eligible and 36 were enrolled. And the control arm consisted of 16 patients and 26 patients in the hydroxychloroquine arm. Of these 26 patients, 6 received azithromycin as well to prevent bacterial infection, not for antiviral purposes. But in this arm, 6 patients were excluded because 3 were transferred to ICU, 1 death, 1 early discharge, 1 discontinued treatment. So this is important to keep in mind while evaluating the value of this trial. And what the authors found was that the patients who received hydroxychloroquine plus azithromycin cleared the virus faster than the control arm or the hydroxychloroquine arm alone. And by day 5, all the patients became PCR negative. So that's really very good news. And therefore, trials started and registered many, many patients. These are the number of trials. This is the yellow line is hospitalized, green outpatients and prophylaxis trials with hydroxychloroquine. As you can see, the hydroxychloroquine trials reached a peak during April 2020. But then after April, there was a sharp decline in the trials of hydroxychloroquine. And it is even less. There's no study right now, but it became very small by the end of July. So what happened? Why did the enthusiasm die so fast? Well, what happened is first, several studies, small studies came out suggesting there may be no benefit of hydroxychloroquine, especially the randomized studies. And there is this study as well. It was published online on May 22. And it was done in 6 continents in 96,000 patients, a multinational registry analysis. And the authors commented that they were unable to confirm a benefit of hydroxychloroquine or chloroquine alone or with a macrolide. And actually, these drug regimens were associated with decrease in hospital survival and with an increased risk of ventricular arrhythmias when used for treatment of COVID-19. This paper was retracted shortly. However, it had its impact. And as the other results came with the hydroxychloroquine, the enthusiasm faded. And in June 2020, 2 big trials decided to discontinue their hydroxychloroquine arm. First, recovery trial after enrollment of 15,000 patients, and then WHO Solidarity trial on June 19 after enrollment of more than 1,800 patients. The arms were discontinued and all the enthusiasm faded. There are several meta-analyses with chloroquine, hydroxychloroquine, plus or minus a macrolide, especially azithromycin. I'm just going to show this one. It is pooled mortality from several trials. Hydroxychloroquine alone, the upper part, as you can see, there's no difference between the treatment arm and the standard care arm. And the lower part is hydroxychloroquine plus azithromycin. And as you can see, standard care is much better because of probably because of the added adverse events of azithromycin to that of hydroxychloroquine. So hydroxychloroquine or chloroquine is out for treatment now in most of the countries, and in Turkey, it was still effective in the guideline of the Ministry of Health until 2 weeks ago. Now it's no longer used, but it's been only 2 weeks. There are other molecules to prevent the viral entry. This is the spike glycoprotein inhibitors, S1 or S2 subunits. And here we have only one medication that has come to the clinical practice, imifenovir or Arbidol, an antiviral. And in this trial, I could find only one trial, clinical trial, randomized trial from Iran, 50 patients in each arm. And on day 1, all patients received hydroxychloroquine plus Arbidol or lopinavir. And what they found was hospital stay was shorter and the oxygen status was better on patients who received imifenovir or Arbidol. So it appears to be promising, but we have only this study. So let's move on. There are the transmembrane serine protease 2 inhibitors, chemostat and alpha-1 antitrypsin. I couldn't find any clinical trials with chemostat, but there are 3 trials with alpha-1 antitrypsin, 3 randomized trials actually, and they have all finished registration or patient enrollment, but none of them have been published yet. So I don't know what came in those trials. I have no idea, but there were 3 randomized trials that were done. As for the other furin cleavage site inhibitors, we don't have any clinical molecules. So these were about the viral entry. So let's move until after the virus enters the cell via proteolysis, the RNA is released so that it can replicate. So here, another set of drugs come forward, the protease inhibitors, and among them only there are clinical trials with only 3 of them: lopinavir, ritonavir, we know from treatment of HIV, tenofovir, hepatitis C, and darunavir, cobicistat, again for treatment of HIV. These protease inhibitors were tried. Of course, we have many or we can say we have substantially more data on lopinavir. But I'm not going to show them all because most of the trials with lopinavir, ritonavir were discontinued early because of adverse events, especially hepatotoxicity. We used it in a few patients, most were pregnant, and we did observe increased transaminases in a good number of them. Or the comparator drug did better than lopinavir. This is why the studies were discontinued. And as for the WHO Solidarity trial, there was no difference in mortality in the lopinavir-ritonavir arm. And in a recent study, a nationwide survey from Korea, there was, again, no effect in viral shedding compared to hydroxychloroquine or standard care. So this drug, we can say it's not very popular in the treatment, or we don't know if it's effective or not. We don't have solid data for that in the treatment of COVID-19. As for Danoprevir, the hepatitis C drug, there is only one trial of 11 patients. So I can't say anything based on 11 patients. It appears to be promising, but this is the data we have. And as for darunavir cobicistat, it was observed that in HIV positive patients who were treated with darunavir, they did better when they contracted COVID-19 infection. However, when this clinical trial was conducted in HIV negative patients with severe COVID-19 pneumonia, and darunavir cobicistat was associated with negative outcome. Actually, we don't know how it's going to do in mild or moderate cases because these are severe cases, but it appears to be non-effective or ineffective in severe pneumonia cases. So let's move to RNA-dependent RNA polymerase inhibitors. And here we have the great bulk of data from the drugs. The most well-known one is remdesivir. There is favipiravir. It's used in a few countries, including Turkey. And there is the molnupiravir. The phase 3 trials are going on, but the inpatient trial was stopped on April 19 because it was shown to be ineffective in hospitalized patients, but the outpatient study is still going on, so we don't know what it's going to show. And there's another hepatitis C drug that inhibits RNA-dependent RNA polymerase, that is sofosbuvir, daclatasphere. There are only 3 trials from Iran. So, remdesivir, we need to talk about it. There are, again, several meta-analyses, including remdesivir use. Here, this is only one of them, a recent one, we can say. In both non-randomized and randomized clinical trials, patients who received remdesivir did better. They were discharged alive at a significant proportion, and they recovered more, both in non-randomized and randomized clinical trials. So this is why FDA gave the license to use it in the treatment of COVID-19. However, in Solidarity trial, the WHO Solidarity trial, the in-hospital mortality is not different from the other arms. There's no difference. In this trial, there's no drug that shows a difference actually in mortality. This is an earlier trial, Act 1 trial, and when we look at the overall data for patient recovery, patients who received remdesivir did better than those who received placebo. However, there is a subset of patients who were on mechanical ventilation or on ECMO, and there was no difference between placebo or remdesivir. And this was again shown in the WHO remdesivir trial interim analysis report. They combined the Act 1 and their results. here we see that patients with lower risk, these are who did not require oxygen or who did not require invasive ventilation, they did better on remdesivir in both trials. However, patients with higher risk, there was no difference, actually. Remdesivir did not affect the outcome. So why does remdesivir fail in critically ill patients? It could be due to its PK and physiochemical properties, because it is unlikely that remdesivir and the active metabolite could reach therapeutic concentration in human lung cells, the target tissue, to inhibit the virus with the current dosing and administration. But when you increase the dose, of course, there is the concern for potential toxicity. Another concern is limited manufacturing compared to demand. This is a pandemic, and the manufacturing of the drug is not sufficient for all the countries that want this medication. Another thing is, again, cost. We know that remdesivir reduces the risk of mortality in low-risk patients. And to prevent one mortality in low-risk patients, the number to treat is 62.5. And this makes $146,000 per life saved. Just imagine this number for a country with limited resources. Another concern, it is for IV use only. However, there are some advances in this matter. For instance, there is a new formulation, self-injectable remdesivir that was developed. And there's another one administered by inhalation, but we don't know the results of this study, the inhalational mode yet. So this can overcome the burden of IV use. And there are some unknown areas for remdesivir. We have limited data on use in pregnancy and lactation, on hepatic insufficiency and renal failure. And we don't know the efficacy when combined with other medications. Maybe it would be much better with another medication, but we don't have much data about it. So let's move to favipiravir. This is a drug from Japan to treat influenza A, and it was used for the treatment of COVID-19 in a few countries where it was available. And in Turkey, after the pandemic started, we started with hydroxychloroquine, that we had the medication, and soon after the pandemic started, we had favipiravir, and we have been using it extensively. Is it effective for treatment of COVID-19? This is the first study. Actually, this was a study that came out online, and one of our colleagues prepared it to discuss in one of our morning meetings. That morning we came and it was just withdrawn. And then it came out in this journal, Engineering. I don't know why engineering, but this is a Chinese journal, maybe that's the reason. However, in the single center study, 56 patients on favipiravir arm and 91 patients in control arm who received lopinavir-ritonavir. And the median time for viral clearance was much shorter in patients who received favipiravir. So it looks really, really promising. But there are few randomized studies with favipiravir. And in this study, improvement in chest X-ray was shown, especially, at day 14. The chest X-ray improved in most of the patients who received favipiravir. These are the randomized controlled trials, and the last one is a retrospective propensity score analysis. As you can see, the number of patients is not much. There's not a big trial as in the case of remdesivir, so we can't say anything. But based on the limited data, what we can say is there is no significant difference in hospital stay mechanical ventilation, or viral clearance in most of these studies. And most of them have been performed, excuse me, in patients with mild to moderate infection, and only one with moderate to severe infection. So favipiravir, there are less data, and the first trial appeared to be promising, but there's not much that came later to support it. Other medications, interferons. Interferon beta 1 alpha is promising in a small randomized trial from Iran. However, it was not effective in mortality in WHO Solidarity trial. This WHO Solidarity trial really makes me pessimistic. Nothing seems to work. Another molecule, ivermectin. There were 3 small studies, 2 retrospective and 1 prospective. In retrospective studies, there was no difference in viral clearance. In the multi-center randomized control trial, only 23 patients, the viral clearance was faster. But again, it's a very small number of patients. Is it really effective? And what is the optimal dose to use? We have no idea. Now let's move to some more general problems in antiviral treatment trials. The clinical trials are reporting. We have the white hat bias. What is it? Well, it is that information is distorted towards promotion of what is widely perceived as fair ends. This could be either in publication of superiority trials. We saw it in other clinical areas as well, or it could be citation bias. For instance, the article citing Act 1 remdesivir trial presented its positive outcomes in 55% of cases, compared to only 6.43% its negative outcomes. So the positive gets cited over and over. And as for hydroxychloroquine, I discussed the first French study, and because although the following studies showed no survival benefit, the original study was the most influential one, and it was cited in many papers. A randomized controlled trial is one of the best to show the efficacy of a drug, yes, and we have big clinical trials in COVID-19. However, there are pitfalls in those trials. The main thing, the most important thing is that in all the completed randomized clinical trials on COVID-19, the patients were randomized based on the respiratory support at randomization, not disease severity. But disease severity is very important. Let's take a hypothetical patient who is on 4 liters of oxygen on nasal cannula. 4 patients requiring this amount of oxygen with the same pre-existing comorbidities, but with different disease severity, as shown with SOFA score. As you can see, when the SOFA score changes, the mortality increases from 5 to 27%. So the randomization, there is a great problem in randomization in clinical trials, when you randomize only based on the oxygen need. So where are we now? There is no solid evidence of an effective antiviral treatment so far. So far, remdesivir appears to be working in low-risk patients, that's all. And antivirals have no impact on survival once the patient is on mechanical ventilation. Nothing seems to work. So what should be done? We need new drugs. New drugs should be developed that aim conserved regions on viral membrane fusion protein domains, and a combination of drugs effective at different steps of the viral cycle in human cell. Then they may be more effective, we don't know. And of course, there is the personalized drug treatment, which may be important, the pharmacogenetic approach. And in order to increase the concentration of the drug in the lungs, use of novel drug delivery systems may be needed. So we, healthcare workers, in conclusion, we need new drugs and we need them now. There is the vaccination, but the pandemic is still going on. And even if this pandemic is over, there are more than 500 coronaviruses identified and around 5,000 estimated not yet identified, all waiting as a silent bomb to explode at one time. So thank you for your attention.
Ömrüm, thank you. Thank you very much for this excellent review. And there are a couple of questions, but we are a little bit late on time. Although you have answered that, I would like to get one of them one more time. And Ramzi Zahir Ali Shah is asking, which drug molecule is more effective against this virus? And if you have to choose one of them to treat your patient, among all those drugs, which one would you choose?
Based on available data, the greatest trials are made with remdesivir, and it is shown to be effective in mild to moderate cases. But once the patient has severe pneumonia, nothing works, nothing. I'm not sure if remdesivir is really superior to other drugs because the others have not been studied that much. I have no idea.
All right. So it means we really don't have a very effective antiviral treatment, as you said. Thank you again, Dr. Uzun, and we will move on the next speaker, Dr. Yazdan Yazdanpanah. Dr. Yazdanpanah is the director of the French Aviation Institute of Immunology, Inflammation, Infection, and Microbiology, and professor of medicine, Paris Diderot University, France. He is a very well-known gastroenterologist and the infectious disease specialist, but we know him with the very detailed studies about the immunology of HIV and hepatitis. And but with the COVID-19, he has a leading role, especially in Europe, through the one of his roles. He is one of the coordinators of INSERM, Reacting, a network under the umbrella of Aviation, research and action targeting emerging infectious disease, the goal of which is to optimize and coordinate the existing research capacities during emerging and re-emerging infection threats. And today, the name of the threat is the COVID, and he has enormous experience about that treatment in many different modalities. And he's going to talk about the monoclonal antibodies and convalescent plasma. Please, Dr. Yazdanpanah.
Thanks a lot, Dr. Sahar, and thanks again for your invitation. So as stated, I'm going to talk about monoclonal antibodies and convalescent plasma. As it was said during the last talk, we know a little bit more, although I think that we have many things to know about this disease, but we now know that we have a viral phase in COVID and a host inflammatory response. And we have been using these drugs regardless of one phase and the others, and probably this is a mistake, and probably we should use more antiviral drugs in the early phases of the disease and anti-inflammatory, maybe with viral drugs at the second phase of the disease. And this is something we had in our center, the first cases of COVID-19. And we really saw this very quickly on the first patients, that when you have images of pulmonary impact, you don't have any more virus. And this is really at least in the PCR on nasopharyngeal secretions. They have many drugs in 2020 that were evaluated, and most of these drugs, as Dr. Uzun said, were repurposed drugs. And unfortunately, it was a huge amount of failure. And also, I have to say, to complete what Dr. Uzun said, we have probably did the things in a wrong way. We didn't use drugs in animal models to see if they're efficacious, we directly use them in phase 3 trials, which is not the best way and the standard to do that. So I'm not going to talk about all that has been talked. I have the same conclusions that has been stated by Dr. Uzun. I'm just going to really emphasize on monoclonal antibodies and convalescent plasma. So there is a huge number of monoclonal antibodies. You have those from Lilly and Regeneron, and from Lilly you have mono and dual therapy. You have dual therapy from Regeneron. You have the dual therapy from AstraZeneca. You have the monotherapy from GSK. You have Celltrion, Tycan, and I'm forgetting some of them. So there is a huge amount of monoclonal antibodies that are emerging. First of all, I have to say that none of these drugs have showed any efficacy in hospitalized patients. It is probably too late to give these drugs in the late stages of hospitalization. You have one of these studies that has been published regarding the monoclonal antibody of Lilly, the BAM, that showed no efficacy in early stages, or in late stages of the disease in hospitalized patients. Of course, I think that we still should look whether these drugs can be active in hospitalized patients, given that because of the use of steroids, because of the use of immunomodulators as tocilizumab, probably we still need, but it should not be probably the dual therapy by Lilly, and also the GSK drug that was not showing, although it's not published, any efficacy. That's why in a trial that we have started in Europe through the EU response and discovery, part of which we have Turkey actually. The idea is to evaluate the AstraZeneca antibody, which is a dual antibody, and to try to use it in hospitalized patients, but in early phases of hospitalization, because antiviral drugs, you have to use it at early stages. So most of what has been reported on antibodies and monoclonal antibodies, it's at early stages. So you have this study that was published in New England. It's in the monotherapy of Lilly. And what you can see is that when you look at the viral load decrease with different doses that were used and the difference versus placebo, you don't have a huge amount of decrease. You have some decrease with one of the doses, which is half a log. And I will come back to that, but you can see in blue, it's the dual therapy, and probably the decrease in viral load with the dual therapy is more important, although we don't know exactly what is the predictive value of the viral decrease. In the monotherapy study that was published in New England, although the number of people who were hospitalized, so the drug was given early stages of the disease. Patients were not yet hospitalized. But you can see that when you give it early, it was shown, although we don't know if it was significant, that it was 1.6% with the monoclonal versus 6.3%. Here you can see it is on a post-hoc analysis that we should be careful, published in JAMA, when you can see patients age 65 years or older or with a high BMI. And you can see that basically, if you can look at the difference, there were some differences with monoclonal versus placebo with the monotherapy, because you have 10% or 7% less risk of hospitalization. However, one big issue with monotherapies is the emergence of resistance. And if you want to avoid the emergence of resistance, it's better to use dual therapies than monotherapies. And you can see this in the JAMA paper that was published, that the proportion of the variants was 7 to 11% in patients on BAM monotherapy versus 4% in the placebo group. And when we look at the high-risk patients, you can see that 9% had actually resistant mutations versus 0% in placebo. Actually, we use this drug in France in our center in 6 patients, very high-risk patient with nosocomial infection. Of course, we can't say anything about the efficacy, but what you can see here is that in 5 out of 6 patients, we had the emergence of 484K or 44A, which are resistance that you have in so-called South African or Brazilian. So we didn't have this emergence in the beginning, but we had it at the end. So that's why we stopped completely to use monotherapies. And there is a study that has been just accepted from the United States that they say the same, that show the same thing. So the FDA has now stopped the recommendation for this drug. And we, in France, we don't use it anymore. What we use, but in expanded access, because we don't have enough data, is dual therapy. And we only use it at very high-risk patients because we don't have enough currently data. We have this clinical trial that I showed you with a decrease of the viral load with dual therapy. The others are mono, but in blue you have the dual therapy. What you can see is on the post-hoc analysis, this study shows that the proportion of patients who are hospitalized on dual therapy is 0% versus 13.5% in the placebo arm. Of course, we should be careful because it's a post-hoc analysis. And also in this study, you can show that the proportion of patients with mutation was only 1% with the dual therapy, so much less than the monotherapy. So we're more reassured about that. However, it is very important also to say that this dual monotherapy is not active neither on South African nor a Brazilian variant. So it's not active when you have the 484V. I will come back to that. We have, of course, another dual therapy that currently it has the expanded access in Europe and in France, which is the Regeneron Roche dual therapy. I will talk about that. For that, which is a dual therapy, one, the casirivimab, it's not active against variants, but the MDVimab is active, although the activity is low. Regarding the Lilly dual therapy, there was a study that was published. It's a phase 3 study. It was not published. It was presented at the CROI. So 517 versus 118 patients, placebo versus the dual therapy. This was mostly patient at risk. And what you can see is that the proportion of actually hospitalization or death was lower in the dual Lilly therapy. This study is not yet published. But currently, again, we use this monoclonal, this dual therapy in patient at high risk. Very shortly after enrollment, we say we cannot use it after 5 days of symptoms, only before 5 days of symptoms. But we need published trials to do this to everyone. And as Dr. Uzun said, we should be careful because these drugs are IV, 1 hour, so not very easy to administer. The other dual therapy that we use is the Regeneron Roche dual therapy, also in expanded access, also at risk patients. And you can see that on the viral load, again, data are not for now extremely important. There are some clinical trials, and you can see that there is a decrease in viral load when you use the drug in patients who are antibody seronegative. When you use them in antibody seropositive, the impact is not good. And this is, so that means that if you use them early, less than 5 days, they could have an impact, but late, they could not have an impact. So that is, again, extremely important. So probably monoclonals are important tools. You don't have issues of safety. You have to use them early for them to be efficacious. We are now having the first generation. We need more to try really to use it everyone, but they are expensive and they're not easy to administer. Now let's come back to the plasma. So there are a bunch of studies of plasma in people with severe pneumonia. And this is one from Argentina, published in New Journal of Medicine, that showed in 228 patients who received versus 105, no differences in the clinical status. So for people who had already severe pneumonia related to COVID. The other one, I will come back. The other study, which you probably know, is the recovery study. The results were launched and published very recently. And again, they showed that in patients with convalescent plasma, there were no improvements of their clinical outcomes with convalescent plasma. And this is the forest plot, where you can see that the effect was not at all good, as you can see. No impact. We can ask, if you can see here regarding respiratory based on no oxygen, oxygen, and invasive, you can see that the later you use it, the worse it is. Of course, we should be careful because there are not that much data. But I think from this, we can say that in hospitalized patients, probably convalescent plasma have no impact. Again, if you come back, this is another Argentinian study where the plasma was used in patient early, within 62 hours after the onset of mild symptoms. And here, what you can see is that if the titer was above median concentration, you have a 73% reduction in patient at early stages of disease to not have any severe diseases or death. So again, for plasma, likewise for monoclonals, if you want to have some efficacy, you should probably use them early. Although I think that we should be cautious regarding this, that this study, Argentinian, which was used in early patients, only a small number of patients would enroll. But I would say then, plasma, maybe, if yes, early stages of the disease. One other thing is important, probably for both, is probably there are some patients who are specific groups who can probably also more likely benefit from plasma or from monoclonal antibodies. These are patients with inherited or acquired immunodeficiency. And this is a French study, actually, that is not a clinical trial. It's a cohort. It's not that much patients, but it shows that in patients who were on anti-CD20, so with a profound lymphopenia and with persistent COVID symptoms and with persistent viremia, when you go give this plasma, then you may have some benefit. So again, you should give these drugs early. In hospitalized patients, for now, never have been a clinical trial showing that it works. Probably in this population, we need other antivirals, or probably we should give them very early. Maybe there are some subpopulations, such as profoundly immunosuppressed patients, where you can use these drugs and convalescent plasmas in particular to try to have some benefits. And of course, the issue of the variants that I have already stated for monoclonals, you will have them also for plasma, because if the plasma is coming with someone who has been actually infected with the historical variant or the historical clade, you may not be efficacious in someone who has another variants, for example, the South African variants. So with this, I will stop. Thanks you again for your invitation, and thanks for your confidence. Thanks a lot.
Thank you, Dr. Yazdanpanah. It was excellent as was usual. And there's one question. You just stated that if the plasma obtained from historical clade is not effective to variant, right? South African or Brazil.
Yeah, I said that we may have some doubts. We don't know that it's as efficacious as, so that is one of the issues. Of course, if you take plasma from someone who has been infected with the variant, then you can give it to someone else with the same variant, but it is not clear that you can use this within the variants.
Theoretically, the answer is no, but the question is, what is the situation if vice versa? I mean, if you get the early convalescent serum from let's say South African variant and give it to the historical clade.
I think that it could be efficacious. I think so, but it's a good question.
Yes, because it gives an idea about the vaccines. I mean, we do the vaccine for historical variant. It's not effective against the variants, but if you have a vaccine against variant, will it cover all the earlier clades?
No, I agree.
Yeah. Okay, and one more question to you from Kumut Kafle. Which patients, mild, moderate, or severe, is indication for convalescent plasma? How much experience we have about it? Is effectiveness in early administration has sufficient evidence? I mean,
no,
all of them partly, but please.
No, I think that first of all, we don't have enough experience. And for me, right now, it's only in clinical trials. In France, what we do in very immunosuppressed patients, we may use convalescent plasma, but only as expanded use. And now that we have monoclonals, we rather use monoclonals.
Yeah. All right. I know you're in a hurry, Yazdan. Thank you very much again for your time and an excellent presentation. Thank you. See you in the other meetings. And dear colleagues, we are going on with Dr. Gül. So far, we have learned that we really do not have an effective antiviral treatment. None of them is working well. Then we have convalescent plasma and monoclonal antibodies. That is very expensive, actually. We cannot trust them either. but we are treating millions of people just to suppress their inflammatory response. So this is the final stage, and Dr. Gül will talk about the treatment of hyperinflammatory response in COVID-19. Dr. Gül is professor of medicine working in the Department of Medicine, Division of Rheumatology, Istanbul University, Istanbul, Turkey. He's a worldwide known researcher and clinician, particularly about the two famous Turkish rheumatological disease, I would say, is Behçet disease and FMF. And we are getting help from his anti-inflammatory experience in the COVID-19 treatment, actually, and he has enormous experience about that. We are very glad to have you here today with us, Dr. Gül. Please. Ahmet.
Now, it's a great pleasure to be with you today, and I'd like to thank again you and the organizing committee for the kind invitation. Well, in half an hour, I will try to summarize what we have learned in the treatment of an infectious disease using anti-inflammatory agents, both general and more targeted treatments. But if we start with the disease spectrum, we know that it ranges from asymptomatic patients to patients with very severe disease, manifesting as acute respiratory distress syndrome or multi-organ failure, which may lead to death. But in between, there are a group of patients with symptoms mainly associated with the expression of ACE2 and causing respiratory findings such as cough, sore throat, anosmia, nasal discharge, dyspnea, and also constitutional symptoms such as myalgia and fatigue. But within this spectrum, our treatment also ranging from a prophylactic treatment, especially in those who are really at high risk of developing disease, such as healthcare workers, or asymptomatic, presymptomatic patients at the very early stages of the disease, or symptomatic patients. Within this period, the virus is replicating, especially during the respiratory symptoms. The virus is reaching the highest level of the replication, and then this replication goes down. But starting from the second week, we are developing a lot of manifestations mainly associated with the immune response against the viral infection. So this inflammatory response is sometimes causing a major tissue damage or most of the complications associated with the disease course. So these inflammatory features are mainly responsible for the diffuse alveolar damage and multi-organ failure. So for the prevention of major disease outcomes, appropriate anti-inflammatory treatment is really playing a critical role. And most of these symptoms, as I told you, are either directly associated with cytopathic effects of the viral infection or immune response. So respiratory findings are usually starting with the direct cytotoxic effects and then associated with the activation of renin-angiotensin system, which is causing different manifestations, but that may also include inflammation and some vascular findings, especially vascular permeability. And at this stage, our immune response is usually starting with a type 1 interferon response. So this is a classical antiviral inflammatory response, and interferons are usually triggered when we see the virus either at the surface of the cell or within the cell, within endosome. So the TLRs are usually triggering a strong type 1 anti-inflammatory response. And this interferon signature is starting early, and the lack of appropriate interferon signature is really critical in the progression of the disease. But at the later stages of the disease, intracytoplasmic viruses are also triggering inflammasome components. So endosomal triggering is involving TLRs, especially TLR7, but intracytoplasmic viral particles or viral antigens are triggering inflammasome, and that is responsible for the majority of later stage innate immune responses. And this increased inflammatory activation are either causing endothelial activation and thrombosis or resulting in a T-cell lymphopenia or hyperactive innate immune response, which are actually causing most of the manifestations associated with either respiratory or other organ systems. So timely and regulated inflammatory reaction is necessary for an effective control of viral infection and healing process. So the inflammation is something necessary to combat our viral infection. And when we are talking about a hyperinflammatory response, which is usually developing after the second week, is somehow different. So in a subset of patients, depending on the host reaction, the body is developing an exaggerated inflammatory response. So similar to Shakespeare's explanation in Henry VIII, heat not a furnace for your foe so hot that it may do singe yourself. So the inflammation itself is actually causing most of the damage. And this is somehow associated with a delay in the type 1 interferon response, and at the later stages is exaggerating the inflammatory reaction by the activation of inflammasome pathway or NF-kappa B pathway. And a dysregulated cellular immune response is also contributing to this inflammatory reaction. And regarding the interferon response and a more severe disease course, there are some genetic and acquired examples. In an analysis of interferon pathway genes, about 3.5% of patients was found to have mutations or inborn errors in 8 out of 13 candidate loci in TLR3 and IRF7 dependent induction and amplification of type 1 interferon pathway. So these are really explaining only about 3.5% of patients with life-threatening disease compared to asymptomatic individuals, but these inborn errors are associated with a delay in the type 1 interferon response. An acquired form of this interferon abnormality is also observed in a group of patients, about 10% of patients with severe disease, manifesting as anti-type 1 interferon antibodies. So neutralizing IgG antibodies can be developed in some healthy individuals against type 1 interferons. And this is present at the onset of the disease, and which is much more frequent in male patients compared to female patients. So these anti-interferon antibodies may also result in a delay in the initial stage of the disease and in our interferon response. So this delay is usually associated with an increased viral load. In normal conditions, a good interferon response is limiting the viral replication and then activating the both other innate and adaptive immune responses, which is leading to development of neutralizing antibodies and also protective T-cell responses. But when there is a delay in the type 1 interferon response, the viral load is becoming much more prominent, either due to inborn errors of the genes or autoantibodies, or sometimes much more severe genetic defects causing type 1 interferon deficiency. So this increased viral load is usually leading to a more aggressive inflammatory reaction induced by these viral antigens, both in innate and adaptive immune systems. So in theory, recombinant type 1 interferon therapy may help to control this dysregulated inflammatory response. However, the big trial data showed that the interferon is not actually providing us what we need in terms of causing decreased mortality. But in these big trials, the major issue is actually how the trial is set. So this is a trial used or conducted in hospital patients. So if it is not used at the very early stages of the disease, if the disease is already progressed to a strong innate inflammatory response, well, the interferon is not providing a critical help. So there is still a room as an anti-inflammatory treatment at the very early stages of the disease, and which has not been answered yet. But when we cannot control these very early stages, and then the inflammasome and NF-kappa B pathways are strongly activated, mainly due to an increased viral load. So if your immune system is not combating the viral load effectively, so the already activated both innate and also cytotoxic T cell responses are causing an increased amounts of cytokines, pro-inflammatory cytokines, which is leading to a cytokine storm, which may involve interleukin-1 beta, interleukin-6, TNF-alpha, interleukin-8, interferon gamma, and it's a very complicated and exaggerated inflammatory response. But in COVID-19, many argued against naming this condition as a macrophage activation syndrome, mainly due to it is probably less prominent feature compared to other forms of macrophage activation syndromes, which is a typical form of cytokine storm. But in COVID-19, it is an alveolar macrophage activation syndrome, so it is limited, at least at the initial stages of the disease, to the lungs. So the site of inflammation is limited, and which is mainly involving macrophages and also other innate immune cells, especially neutrophils, at an exaggerated state. And many pro-inflammatory cytokines, IL-1, TNF, IL-6, IL-18, and interferon gamma are contributing to this inflammatory response. And at later stages, we also observe a problem in the cellular immunity, mainly by a decreased amounts of lymphocytes, both in B cells and T cells, and also a dysfunction in NK cells, which are really playing a role again in controlling the viral replication and then causing a tissue damage. So when we see the adaptive immune response phase, we see a lymphopenia and also a scarcity or loss of germinal centers in the lymph nodes, which is another typical feature of COVID-19, which is actually resulting in a very short-lived memory. So we are still discussing how long the immunity will survive in those patients who already got COVID-19 or vaccinated. So it is mainly associated with the B cells in the germinal centers and their short-lived memory due to scarcity or loss of germinal centers. But after this, the induction phase of cellular immunity, again, which is causing an increase in IgM and then IgG neutralizing antibodies that are being used, as already mentioned, in the treatment of some patients as either convalescent plasma or monoclonal antibodies. But at later stages, disease is again turning into an innate inflammatory response with a macrophage activation involving several pro-inflammatory cytokines and causing vascular abnormalities with increased neutrophil extracellular traps, immunothrombosis, and also many other ischemic findings. So how can we explain this exaggerated inflammatory response? It may either be due to viral part of the infection or some host factors. So the viral load, viral entry route, and maybe some variants associated with the severity of the disease. But there are a lot of factors resulting from the host genetic and epigenetic factors. So some genes, especially some rare variants in TLR7, may explain this ineffective type 1 interferon response, and also some ABO blood group polymorphisms may contribute to the inflammatory response, and especially epigenetic factors, depending on the history of vaccination or previous infections. Your innate immune system may be either activated or ready for a second infection due to trained immunity, may also explain the amount of inflammation you are developing when you are exposed to viral antigens. Male sex, advanced age, hypertension, many other comorbidities are also playing a role in the development of this exaggerated immune response. But the dynamics of inflammatory response is really critical in the differentiation of normal inflammatory reaction we are expecting during the course of the disease, and also exaggerated or cytokine storm form of macrophage activation syndrome in a subset of patients. And when you follow those patients who are developing a severe disease, there are some items showing us that the macrophages are really activated in a different stage. So cross-sectional evaluations are usually misleading, but when you follow the patients day by day by consecutive measurements of some inflammatory markers, especially ferritin, can show a dynamic increase compared to their first day values within the first week. So at around the 7th or 8th day, it reaches about 2.5 or more times higher concentration in those patients developing a severe disease. We can also say the same thing for the dimer. The dimer is also reaching very high levels in the first week, about 1.5 times higher compared to their initial baseline values. So in patients with fever, high ferritin values, high neutrophil count and low lymphocyte counts, increased D-dimers, increased LDH and hepatocyte enzymes, and also low procalcitonin levels, we can easily identify those subset of patients with this exaggerated inflammatory response. And after the identification of this subset, it is really critical when you interfere with this inflammatory response. So in normal inflammatory response, which is developing again at the first week of the disease and causing a very limited alveolar damage, which is really helpful to limit the viral replication and the infection course. But in those individuals with an exaggerated inflammatory response, the alveolar damage is a progressive event. And if you stop this inflammatory response at early stages, you may also limit the alveolar damage and the patient survive quite effectively. But if you start the anti-inflammatory treatment lately, at that stage, maybe alveolar damage is too much progressed to very severe forms, and it may be really difficult to control the respiratory findings, even if we can suppress the inflammation. So what are we using for the treatment of these inflammatory features of the disease? And glucocorticoids are the most commonly used anti-inflammatory drugs, but previous experience with viral infections or other serious infections was not very good. So there are always warnings about not using glucocorticoids, at least not using them at high doses, because it may impair the immune response to infectious agents. Especially glucocorticoids can induce lymphopenia and neutrophilia, very similar to the COVID-19 itself, with the increased doses of corticosteroids. And when necessary, it can be used as 0.5 to 1 milligram per kg as prednisone or equivalent doses of other glucocorticoids such as dexamethasone or methylprednisolone. But we have to keep in mind that glucocorticoids have pleiotropic effects. So we can use them as an anti-inflammatory, but they are also immunosuppressive agents. So if you start them at the very early stages of the disease, it may show deleterious effects in the infection's course. So you may easily cause the progression of the viral replication if you start them very early. It may stop the increased vascular permeability, so it may really help to control some of the respiratory findings in addition to its anti-inflammatory effects. And at the later stages of the disease, it may also provide us some antifibrotic effects, which is really critical for controlling long-term complications of the disease. And the best clue came from the recovery trial for the beneficial effects of dexamethasone. And dexamethasone was actually the first drug which was shown to be effective throughout the pandemic period. So the recovery trial using dexamethasone 6 milligram per day, either IV or oral in 10 days or less versus standard of care, showed us that regarding the reduction in mortality on day 28, especially in those patients who are on mechanical ventilation, dexamethasone group showed a statistically significant reduction in mortality rate. So 29% patients in dexamethasone group survived, got a better mortality rate compared to increased mortality in standard of care, 40.7%. And dexamethasone may also show some beneficial effects in those patients requiring oxygen support. So 21.5% mortality in the dexamethasone group in this subset of patients was much better than the standard of care, which provided 25% mortality. But in those individuals who are not requiring oxygen support, dexamethasone was not beneficial, and it may even cause some form of harm. So 17% mortality in dexamethasone group versus 13.2% mortality in standard of care. So dexamethasone, especially in those patients requiring mechanical ventilation or milder forms of oxygen support, benefited more from dexamethasone treatment when it's used at moderate doses, 6 milligrams per day, either IV or PO. And there are now lots of different glucocorticoid treatment trials at different dosages. And these trials showed us that higher dosages actually not providing us more benefit. And especially dexamethasone at 20 milligram per day dosages compared to 6 milligram per day provided a similar range of favorable effect. It's also true for hydrocortisone at 100 milligram or 2 times 40 milligram methylprednisolone provided more or less similar favorable effects to standard dexamethasone 6 milligram per day dosages. So the dosage is really critical in terms of its beneficial effects. And regarding its adverse events, again, increased doses of glucocorticoids are also associated with increases in the serious adverse events. So it is beneficial and it is associated with less adverse events when it's used at moderate dosages. So for higher dosages, there is no reliable data regarding its efficacy and safety. And also a variability of inflammatory response may require dose adjustments in some individuals. Although we are talking about the standard dose, in some patients, depending on the severity of inflammatory reactions, you may need maybe higher dosages if you do not have any other alternative, more targeted treatment options. And if you are also aiming non-genomic effects of high-dose glucocorticoids. But when you use them at high dosages and maybe longer duration, you always keep in mind the increased risk of opportunistic or secondary infections. So we are seeing a lot of patients with Acinetobacter, Klebsiella, mycosis infections, and higher dosages are usually prolonging the hospitalization and resulting in prominent lymphopenia or neutrophilia, and they are also associated with myopathy and many other catabolic and metabolic effects. So for the treatment dosage and duration, it's always better to keep it at moderate dosages and less than 10 days. And as it has been discussed extensively in the previous 2 talks, for the treatment of COVID-19, we had several different options tested. And so far, the second drug or second type of effective treatment came from another anti-inflammatory agent, anti-cytokine treatments, aiming to block the activity of IL-6, so tocilizumab or sarilumab. So more targeted anti-inflammatory treatments, mainly aiming IL-6 or IL-1, may really help to control the inflammatory reaction on top of glucocorticoids when the inflammation is more extensive and out of control. And some JAK inhibitors, especially baricitinib and IVIG, may also provide additional anti-inflammatory help. But when you look at the clinical trial data, there are conflicting results, mainly due to these trials were planned for respiratory findings, not for the hyperinflammatory features of the patients. And when you look at the anti-IL-6 trials data, there are many open label and trials, and also some randomized clinical trials. But there are conflicting results. meta-analyses are usually providing favorable effects. And when you look at these subgroups of patients with favorable response, when the control group is matched according to lymphopenia, high ferritin levels, or normal procalcitonin values, instead of respiratory findings, you are seeing more favorable effects when you block IL-6. And we also know that COVID-19 pneumonia and alveolar damage are associated with different inflammatory and vascular pathways. And macrophage activation syndrome or hyperinflammatory response is one of the leading mechanisms of alveolar damage, but it is not a single cytokine disease. There are several cytokines responsible for the hyperinflammatory response, and the timing and the timing of the treatment and the co-medications are really critical in the efficacy of these type of treatments. So this slide is summarizing several clinical trials conducted by using anti-IL-6 treatments. Again, depending on the stage of the disease, there are some conflicting results. So it should be used during the symptomatic phase of the disease when there are signs of hyperinflammatory response, but the disease should not be progressed at later stages of the disease, because in these stages, the favorable effects cannot control the outcome of these patients. So before reaching to critical disease, these drugs may really control the inflammation, especially when it's been used along with glucocorticoids. And in the previous randomized controlled trials conducted in very developed clinical centers provided some negative results. For example, the one by John Stone and colleagues showed no difference between tocilizumab and standard of care in hospitalized patients when they are, again, randomized according to their respiratory and inflammatory findings. And the other one, GMAP-CAP, provided some difference between tocilizumab and sarilumab compared to controls. An IMPACTA trial showed at least 44% less mechanical ventilation or that outcome in the tocilizumab group compared to controls. And none of these trials showed an increase in the risk of infections. But the recovery trial, again, provided the final answer for the efficacy of these trials, and mainly because of it is, again, the size, which actually included a larger group of patients, and also this trial was conducted after the success of dexamethasone. So 82% of patients were on dexamethasone. So when the tocilizumab used on top of dexamethasone, at least in a group of patients, it clearly showed a favorable effect on the mortality and also a favorable effect in the discharge rate alive from the hospital. So it is really providing a survival and also clinical finding effects in those in hospitalized patients. And this meta-analysis is showing us the summary of the findings, and especially most of the information is coming from the recovery data with its large size, and they all show a favorable effect in those patients using tocilizumab. Again, these effects are associated with the inflammatory features of the patient, so it should be used in those with hyperinflammatory response. The clinical stage of the disease, it should be used at a relatively early stage before reaching to mechanical ventilation or later stages of the disease, and it's helpful when it's used in combination with glucocorticoids. And another target is IL-1. So anakinra, as an anti-IL-1 treatment, is really a helpful target, which it has a very short half-life, but it requires daily, usually one or more times administration. But its dosages should be adjusted according to patient's requirements with a range of 2 to 10 milligram per kg per day. And it can be used sub-Q or IV, depending on the patient's requirement or the dosage required. And there are very good experience in other causes of macrophage activation syndrome. And there are several case reports documenting the favorable effects of anakinra in patients with hyperinflammatory response. But in some controlled trials, the drug response is controversial, especially the one which is published recently. But these trials are usually giving anakinra at certain period, for example, just 5 days at standard dose, for example, 400 milligram per day as the highest dose. And when necessary, they just add 3 additional days, but it is not usually enough to control inflammation. For anakinra treatment, I'm using always the analogy of insulin in diabetes mellitus. The dose and the duration of anakinra treatment should be adjusted daily according to patient's requirements. And a standard dose approach for standard duration is usually not appropriate for IL-1 blockade by anakinra. And previously, in the treatment of sepsis, anakinra was again found to be effective only in a subset of patients with findings of macrophage activation syndrome manifesting as hepatobiliary dysfunction and coagulopathy, which provided about 30% reduction in mortality rate. And lastly, the inflammatory response or hyperinflammatory response starting in the second week of the disease is actually not the only strong inflammatory response. After an asymptomatic period, some individuals, especially children, are developing another hyperinflammatory response. And this systemic inflammatory response is usually manifesting as endothelial activation or vasculopathy, a Kawasaki-like disease, a coagulopathy, in some patients cardiomyopathy, and interestingly, very high levels of procalcitonin. And we are observing a good number of adult patients as well developing the disease after an asymptomatic period, possibly associated with the autoantibodies interacting with different cell tissues. So in addition to this multisystem inflammatory syndrome in children and adults, some patients may also develop autoimmune or autoinflammatory features after their adaptive immune response produces antibodies, which may overlap with some of these self-antigens. So in conclusion, and as take-home messages, hyperinflammatory response may develop in a subset of patients with COVID-19, and this may contribute to the worst outcome of the disease. And using the right anti-inflammatory agents at the right time, at the right doses would be critical for having a favorable response. It is also necessary to pay attention to the risk-benefit ratio. And glucocorticoids are the cheapest and the most commonly used anti-inflammatory drugs, and they are not appropriate in early phase of the disease. Efficacy and safety data are available only for moderate doses when it's used less than 10 days. And for using them at higher dosages or longer duration, the decision should be made individually depending on the risk-benefit ratio. And for the anti-cytokine treatments, we really need to identify those patients who would benefit more from these more targeted treatments. So the timing, dose, and additional treatments, especially glucocorticoids, are important. And decision based on the dynamic changes of the inflammatory markers, especially within the first week of the disease. And the prevention of secondary infections associated with immunosuppression is important, and which is occurring at the later stages of the disease when it's used very high dose of glucocorticoids. And of course, anti-inflammatory treatments are important for the prevention of late complications of the disease, especially the fibrosis and other respiratory findings. So anti-inflammatory and antifibrotic treatments should also be considered during the course of the disease, depending on the patient's requirements. So I hope it may provide you more questions than answers for the future of the viral infection, which could be treated by anti-inflammatory agents. Thank you very much for having me.
Thank you, Professor Gül, for this very excellent presentation. And there are lots of questions to you, and I'll try to ask you as long as we have time. Already out of time, actually. What is the explanation for better activity of dexamethasone over other glucocorticoids? Dr. Kumut Kafle is asking you.
Well, to be honest, there is no strong data that the dexamethasone is superior to the similar doses of methylprednisolone or prednisolone. So it is easy to use. It has a long-acting drug, and it has a good anti-inflammatory profile. But similar results can also be obtained at an equivalent doses of methylprednisolone as well. So it is not unique to dexamethasone.
And Dr. Sasibusan Kushua is asking how long the use of corticosteroids. You already mentioned that it's generally less than 10 days, right? Any special circumstances that we have to use longer period of time? And what is the problem with that? He's asking.
Well, the data is for less than 10 days, but especially with the variants, we are seeing some patients with much higher, much stronger inflammatory response. So the standard dose sometimes are not helping to control the inflammatory findings. So in these individuals, we do prefer to use more targeted treatments, which are helping us to reduce the need for glucocorticoids and controlling inflammatory response with more targeted treatments like anakinra and tocilizumab. So when you are able to use these anti-cytokines, it's better to reduce the steroid dosage and to get rid of them as soon as possible. But we also need them at low dosages as an additional treatment, since tocilizumab is not usually effective without glucocorticoids. So it should be adjusted depending on the patient's requirements. And you have to be very careful, especially for the secondary infections.
Thank you. Professor Gül, you mentioned about the maximum dose of 1 gram per kilo, but you said that it's not necessary to use the higher doses, but there are rare publications talking about the pulse steroid treatment, 1 gram consecutive 3 days. Do you have any experience about that, or what's your comment on that?
Well, I'm a rheumatologist, so I have an experience a lot with pulsed glucocorticoids in autoimmune diseases, but we are not using them in COVID-19, but I am aware of some individuals using high dose of glucocorticoids. And to be honest, our experience is showing us that if it is macrophage activation syndrome, if it can be controlled by moderate dose of glucocorticoids, it can be controlled. If it is requiring much higher dosages, usually pulse steroids are not helpful, are not enough. So it is really necessary to think other treatment options earlier than considering pulse steroids. It can be considered only in those circumstances when you do not have another choice. So if it is your only choice, and if you're not controlling inflammation, you can consider them. And it is really not necessary to use as high. So when it comes to high dose steroids, 250 milligram or even 500 milligram, are usually providing almost equal results with 1 gram methylprednisolone.
Okay, and another question about the cytokine blockage, the interleukin-1 and interleukin-6 blockage. Is there any factors that helps us to prefer one to another, particularly related to patient itself?
Well, I mean, there is still no good data, especially if you are using some biomarkers as an indication of tocilizumab. IL-6 is usually used as a biomarker of disease activity and an indication for tocilizumab use. I think that is not relevant. IL-6 is a very good acute phase response, usually correlating well with CRP values. And IL-6 is usually considered as a surrogate marker for IL-1. So we cannot rule out the combination and their effects. We cannot separate them. I do advise you to select one of them depending on your experience. So tocilizumab is easier to use, just 1 or 2 shots, IV infusions. But for anakinra, you have to use them for a longer period, and you have to adjust the dosage daily. And you have to be really experienced with anakinra if you want to use it in an effective way.
Okay, thank you very much. There are some more questions, but unfortunately, we are out of time. And I'd like to thank you all 3 distinguished lecturers for their excellent presentations. Dear colleagues, we came to the end of one of our web-based seminar from ISAC, and thank you all for contributing or for joining us today. And we will keep up these webinars, and we will see you again at the end of next month, June, with another subject. Thank you all. See you in the other meetings. Thank you.